Okay, people, we are going to have our review on exam number 6 that will be next Monday, starting bright and early at 8 a.m. If you're an overachiever, you can start it at 7:40, I think. Anyway, you can come early. Okay, so we're going to cover adult cardiac, we're covering vascular system, and we're covering hematologic system. So here we go. So first of all, we're going to start with adult cardiac, and you're going to have to know what the risk factors for coronary artery disease are. If you'll remember, we talked about non-modifiable and modifiable risk factors. So you'll need to be able to differentiate between the two and to know what things we can control and what we can't control. Remember that African Americans, women are at highest risk for developing coronary artery disease. Just review your notes over the risk factors and who is most susceptible to developing coronary artery disease. So, and be able to differentiate between what we can control and what we can't control. Then we're going to also talk about metabolic syndrome, and let's talk about that for just a little bit. Remember, there are 5 criteria that are listed, and for a person to be diagnosed with metabolic syndrome, you have to have 3 of the 5 characteristics. So just to remind you all, it's a person that has central obesity. For men, it's greater than 40 inches, and for women, it is greater than 35 inches. If they have hyperlipidemia, if they have hyperglycemia, if they have hypertension, if they have a low HDL, with men having less than 40 milligrams per deciliter, or women less than 50 milligrams per deciliter. As far as the hyperglycemia is concerned, anything over 100 milligrams per deciliter qualifies it as being a characteristic of metabolic syndrome. So remember, we only need 3 of the 5. So just keep that in mind. Also, we are going to need to know what the characteristics of stable angina are, what the characteristics of unstable angina are, and what the characteristics of myocardial infarction are. We need to be able to differentiate and to see what is different between each of those diagnoses. So if we're talking about stable angina, which is usually associated with coronary artery disease, then remember, it's predictable, and it's usually the result of an increase of oxygen demand. It lasts less than 15 minutes, and it's relieved with rest and nitroglycerin. So if you have somebody that is having chest pains, you want to lie them down and you want to give them a nitro tab. And really, remember, I told you that they really can't describe the pain with this. It's just, they don't refer to it as pain, that it's just an uncomfortable feeling in the chest. Then if we were looking at the characteristics of unstable angina, know that it is unpredictable. It can happen even when the person is at rest. It lasts greater than 30 minutes, and it's not relieved with nitroglycerin, no matter how often they take the nitroglycerin or how many times they've taken it. For example, if they take it and then 5 minutes later take another one because it is not relieved, or they take another one when it's not relieved and then they decide to go to the ER. It's just the pain is not relieved with nitro. It can only be relieved with opioids or narcotics such as morphine. And then when you have signs and symptoms that are associated with unstable angina, you're going to have radiating pain. Like I said, it can occur without or occur with rest. There's no really precipitating cause for the pain. Again, it can only be relieved with narcotics, and it lasts longer than 30 minutes. Oh, I think I just said that. Sorry. I'm just going along with it. The signs and symptoms that are associated with it are going to be extreme fatigue, palpitations, it's just real pounding in the chest, epigastric distress, so anyway, they'll feel like they're going to throw up, dizziness, disorientation, or it can even be acute confusion. So I think I remember talking about having some atypical symptoms of unstable angina or MI with two populations, the elderly and women. And so with elderly, those associated symptoms that occur with unstable angina or MI are going to be a shortness of breath. They're going to be extremely weak, and then they'll have nausea and vomiting and palpitations. They'll have a feeling of anxiety or impending doom. With women, many times they come in complaining of indigestion or GERD. They have this feeling of heartburn and they can't get any relief for it. They may have some radiating pain, but again, they're going to have shortness of breath and weakness as well. And they may also experience some nausea and vomiting. When we are talking about nitroglycerin and dosing for nitroglycerin, remember I talked about that this is only going to be dosed by the preference of the physician who's doing the dosing. So in other words, there are some times that a physician will say, take a nitroglycerin if your pain hasn't subsided in 5 minutes, take another one, and then if it hasn't subsided, take another one, 5 minutes apart, and then go to the ER if it hasn't subsided after 3. But other physicians are much more conservative, and they said if pain has not subsided after 1 dose of nitroglycerin, then you need to call your healthcare provider or go immediately to the ER, which I personally think is the better of the two options, because remember, we're talking here that time is muscle. In other words, we're talking about the heart muscle. So the sooner that we can get this problem resolved or get some relief to those coronary arteries, the less damage to the heart muscle is going to occur, which can then affect a person's quality of life afterwards. So when we have somebody that has chest discomfort and they come into the ER, what are we going to do for them? First of all, we're going to check their ABCs and their vital signs. Vital signs are going to tell us a lot about what's going on with the heart and the cardiovascular system. Blood pressure is going to let us know if the person maybe suffered some fainting spell, and so they come in not knowing why they fainted. But we're going to find out if they're hypovolemic or if their blood pressure is extremely high. It's going to let us know if there's a regular heartbeat, if there isn't, and if they're tachycardic or not. We do want to get them on a 12-lead ECG, and we want to maintain their SATs above 95%. We will give them an aspirin of 162 to 325 milligrams. And remember, it needs to be non-enteric because we want it to act as fast as possible and get absorbed. Nitroglycerin, of course, is one of those interventions that we will implement. And then we will utilize morphine for pain because, again, the aspirin is being used for so that platelets don't adhere to each other, forming potential thrombus. On the other hand, morphine is the only thing that's going to address the type of pain that they have. So these are priority interventions for somebody that's coming into the ER complaining of chest discomfort. Remember the textbook had Mona, morphine, oxygen, nitroglycerin, and aspirin as priority interventions, but I've added it to a couple of them here, which is the ECG and the vital signs and the ABCs. So, another thing we need to do is what diagnostic labs are drawn to confirm a diagnosis of myocardial infarction. So remember that troponin is going to, I'm sorry, I just goes there. Can you tell? I just kind of faded away into Neverland. Anyway, for troponin, those enzymes are starting to get released about 4 hours after the event begins, and they will stay elevated for 7 days. And really, this is the best indicator to determining that a cardiac infarction has occurred. It is the best indicator whether a person has had a heart attack and muscle injury has occurred. The CKMB is creatinine kinase MB, and it used to be good, but this is not specific to the heart muscles. So these things the MB is specific, but anything that creatinine kinase, those enzymes will be released with any kind of muscle injury. Myoglobin rises before the CKMB or the troponin does, and it is 99% indicative of an MI, but it's only going to be elevated for about 18 hours after the onset of chest pain. So people that go in and have been trying to get some relief for a day or two, this is not going to be a good lab to choose. So if you're going to choose a gold standard for lab work to determine whether or not a person has had a heart attack or is experiencing one, is going to be the troponin. All right. We did talk about some of the interventions that are going to be implemented for a person that has or is experiencing a myocardial infarction, and that is the reperfusion methods. What are we going to do to get blood back into the coronary circulation so that the heart muscle will get some oxygen? So there's going to be the thrombolytic therapy, which we talked about. It's the ATP, the streptokinase, or the TPA, and it has to be started within 1 to 6 hours of the onset of symptoms. It's only short term, but the goal is to administer it within 30 minutes of arrival in the ER or within 10 minutes of a confirmed STEMI. So the problem with thrombolytic therapy or with these medications is that it causes an increased risk for bleeding. And this can be a hugely problematic in that it can cause someone to have a stroke. Another reperfusion modality is going to be the balloon angioplasty. And the thing about that remember, that's where we're going to insert a catheter up through either the radial or the femoral arteries, straight up to the heart. And whatever coronary vessel is being occluded, they're going to slip in this catheter and then expand the balloon, very much like the balloon on a tip of a Foley catheter. But they'll expand that balloon, which will cause the sides of the coronary vessel to open up, and there will be a greater lumen, and then there will be greater blood flow. And then that catheter is removed. A stent, on the other hand, is going to be threaded up through the coronary vessels as well. And wherever there is a narrowing of that artery, they're going to put that stent in there, expand it, and keep it in place, which will ensure an open lumen in the area that previously had been narrowed or occluded. So those three types of reperfusion methods are usually used when a person is experiencing a heart attack, is having some kind of unstable angina, which results in injury or damage to the heart muscle. Okay, so what interventions are going to be implemented for a post-catheterization patient? First of all, you're going to assess, this is for the nurse that is in post-op. They're going to assess the insertion site. And what are we looking for? We're looking to see if there's any drainage or if there's a hematoma developing. Because if there's a hematoma developing underneath the skin, it's indicative that the artery is continuing to bleed. So we want to keep the person initially and on bed rest for up to 6 hours. We want to then get the person, when they've made sure that that artery has sealed up a little bit, that they begin ambulation. And we have to make sure that we're not overdoing it. Remember, we want them to be active, but not enough to cause them to become unstable. Because remember that heart muscle has been damaged, and it's not going to be able to meet the oxygen metabolic demands of the body. So if the heart rate increases by how much? Do we remember? 20 beats per minute. Or if the blood pressure increases by what? 20 millimeters of mercury, then we need to stop the activity and let the person rest. So 20/20 there. And then also when they're sleeping, we do want to raise the head of the bed up 90 degrees if at all possible. All right. We then talked a little bit about heart failure. We talked about right-sided heart failure, and we talked about left-sided heart failure. So when we're talking about overall symptoms, signs and symptoms of heart failure, what we're looking at here is shortness of breath. Why? Because there's not enough oxygen meeting the metabolic needs of the body. And so therefore, we're trying to suck in more air to get more oxygen into the blood that is flowing systemically. But there's also going to be crackles in the lower lung. This is potentially if there is left-sided heart failure where pulmonary congestion begins to build up. The person will have a pink frothy sputum that is associated with pulmonary edema, which can also be left-sided or right-sided heart failure. A person will have an early morning cough with the left-sided heart failure. And this is one where you have that smoker's cough where they just are hacking in the morning. And why is that? Because they have this fluid in the interstitial tissue of the lungs, which is moving eventually into the alveoli, which they're trying to bring up. But this is not mucus. This is not sputum. This is fluid in the interstitial tissue. So where they have this feeling that they need to cough, they can't bring up the cough because the fluid's in the interstitial tissue, and not necessarily in the alveoli yet. If with right-sided heart failure, there's going to be lower extremity edema. We talked about that. And then the confusion because there is decreased oxygenation delivery to the brain. Talked a little bit about vascular dementia as well. So what are some guidelines for a heart healthy diet? Because diet is definitely going to be one area that the nurse is going to talk to their patients about that are going home. Remember, once the heart has started to fail, it is long term. There's no fixing it. So we want to slow the progression of the disease process. So we're going to change, we're going to make sure they...
You are currently the only person in this conference.
Did you hear that? The only person in this conference. Isn't that so sad? It's so sad. Anyway, so there's going to be decreased... Anyway, so one of the areas that we're going to talk about is nutrition. We're going to talk about medication. We're going to talk about watching their weight, and we're going to talk about activity. So these are the 4 areas that we implement interventions with when a person's in heart failure. So with guidelines for a heart healthy diet, first of all, we decrease salt intake. And we have to really watch out for salt substitutes because they are high in vitamin K. Oh, that is so wrong. Why did I say vitamin K? Because I was thinking anemia in the vascular. No, they're high in potassium. Go ahead, shoot me now. Mock me, send me a text, let me know that was stupid. I agree with you 100%. Anyway, we also want to develop a list of food that the patient likes that are low in sodium. And we also want to encourage them to drink 2 to 3 liters of fluid a day as long as they don't have fluid overload. If they have fluid overload, they're going to be on a fluid-restricted diet. Okay, fine. Okay, so what does a nurse check when a patient is perfusing, or you're checking a person's perfusion or circulation status? It's the 1, 2, 3, 4, 5. Jody taught you that in point 5, so remember that you kind of refresh yourself on that. I would suggest that you know the definitions of pitting edema as far as the scale is concerned, what +1 to +4, what the definitions are for that. Let's see. I think that's all for, let's move this back a little bit. I think that's all for adult cardiac. I want to go over. If you have any questions for it, be sure and text me. Be sure and review the pathophysiology of the heart failure there. I think that's all. So let's move on to vascular. So what is venous insufficiency caused by? And basically it's a valve problem. I think we talked about that. It's due to aging. It can be dysfunction, or it can be the result of a DVT that is causing the valve to stay open a little bit. So what are the signs and symptoms of venous insufficiency? First of all, there's going to be ankle and leg swelling. Why? Because all that blood is not being able to move forward or upward in the venous system. And so because of gravity, the blood is pooling down in the ankles and lower extremities. They may have varicose veins in their legs. They'll have stasis dermatitis, which is basically that reddish brown color that we showed a few pictures of. And then these little capillary leaks develop, causing a discoloration of the skin. And the brown color itself comes from the heme and the hemoglobin that is staying in the skin and the tissues, which give them that brown color. So you may also have some stasis ulcer, very, very difficult to heal. And are the pulses going to be present? I think I asked that question already in class, and it was yes, because this is the venous system that we're talking about, not the arterial system. And the symptoms of venous insufficiency are going to be much less in the morning. Why? Because they've had their legs elevated all night long. One thing that we didn't talk about yesterday that it's not on the test, I just thought it would be real interesting to point out to you that how long does it take for a thrombus to resolve? You know, if they're not going to be candidates always for ATP or streptokinase or TPA. So we have to let this thrombus get reabsorbed into the body. The heparin therapy and the oral Coumadin or warfarin therapy is used to make the blood thin so there won't be any new clots develop. But if it's a really large thrombus that we're talking about, the person can be on anticoagulants for up to a year. And some small thrombi can take up to 6 months to dissolve or get reabsorbed back up into the body. So this is long term. If a person develops a blood clot, usually prophylactically, the doctor will go ahead and prescribe that they are on anticoagulants for the rest of their lives. Okay, so what are some of the interventions that the nurse is going to implement for a person that has venous insufficiency? So we're going to have them elevate the legs 20 minutes, 4 to 5 times a day. We're going to wear elastic or compression stockings. And I have to tell you, these are the 2 priority nursing interventions for somebody that it has venous insufficiency. Why? Because it's going to reduce the amount of edema that accumulates in the tissues, compressing the blood vessels, which can ultimately cause ulcers. And so that's why they're considered priority interventions. But other interventions or education that we want to give those patients is that they don't cross their legs, and we do not want them to elevate we do want them to elevate their legs above the level of the heart. Again, gravity is going to assist in bringing that blood back to the heart, and thus that's why we want them to elevate their legs higher than the heart. We want them to avoid standing for long periods of time. We don't want them to wear restrictive clothing and avoid Spanx. Yeah. Okay, Mark? Yeah, okay. All right, so then we also talked about peripheral arterial disease. So what causes peripheral arterial disease? There's chronic progressive narrowing of the arteries in the lower extremities. And that narrowing can cause obstruction, or it can cause the vein or the artery to become totally occluded. And that's really, really not a good situation to be in. So remember, I told you there's 4 stages to it. So stage 1 is asymptomatic. It's just like with the heart or any place else that atherosclerosis is causing the lumens of the vessels to narrow. These are the arteries, remember. But this is why we call hypertension silent killer, is because you have no idea that these symptoms or these the problems are developing within the human body. And so it's asymptomatic. People don't make many changes. However, with stage 2, which is known as claudication, this is where the body has an increased need for oxygen, or the legs have an increased need. Why? Because they're walking, they're active. So at times they will, with activity, the legs will start to cramp and really hurt really bad. And then with rest, the pain will subside. That is called claudication. And so we know that with an increased need in oxygen, those arteries are going to require more blood, but they can't get more blood. Why? Because we have atherosclerosis of the lower extremity arteries. And that is going to cause an insufficient oxygen supply, which is going to cause the pain. But if we rest, we reduce the oxygen demand on those muscles, and so the legs will quit cramping. However, the disease, peripheral artery disease, will progress into rest pain, where the person, even at rest, has these cramping legs. Very, very problematic and hurtful. It just really hurts. And so then we know that the lumens are really narrowed quite a bit, if not occluded, through a DVT. And then again, this will eventually, if the lumen is so occluded or obstructed, then it's going to result in necrosis and gangrene in the distal part of the occlusion. Oh my gosh, put a gun to my head. All right, so what are the signs and symptoms of peripheral artery disease? First of all, pulses are not present, and they may be greatly, greatly diminished. Also, there's going to be severe pain below the area of the occlusion. They're going to be very cool or even cold. They're mottled, which is this purple marble look to the legs. They can even be cyanotic, totally cyanotic, if the artery is totally occluded. They may have small black dots where capillaries have burst. And of course, the nerves of the lower extremity are going to be affected too, so they will have some numbness and tingling or paresthesia. So what can the nurse implement for a patient that has total peripheral arterial disease occlusion? We're going to notify the RN immediately, or if you're the only one there, notify the healthcare provider immediately. We want to elevate the legs, but we want them lower than the heart. Dangling may be too painful because of the paresthesia. Dangling is also an intervention that we can implement to increase the blood flow to the lower extremities. But if there's a total occlusion, we want them to elevate it a little bit and notify the doctor immediately. But we do not want the elevation to be higher than the elevation or higher than the heart, because then again we are pushing blood against gravity. We also want to keep the leg warm, because what? Warmth vasodilates the vessel. Makes sense, doesn't it? Yeah. So what guidelines are we going to educate a patient on that has peripheral artery disease regarding foot care? First of all, we want to keep the feet clean and wash them with mild soap and water. We want to keep the feet dry, avoid injury to the feet, don't go barefooted, keep the toenails clean and filed, prevent exposure to extreme heat or cold, and never use a heating pad with the feet or on the feet. Avoid constricting garments, and be sure to keep the foot lubricated or the feet lubricated so they don't dry out and crack. And of course, we want to see a podiatrist frequently. I think that's all for vascular. Pretty sure that's all for vascular. So let's go back to hematologic, or your lab values. This is where blood cells are made. Oh, I mean, this is not where blood cells are made. This is where it's Wednesday and I'm tired. I know you guys are tired too. Why? Because you just had a pharm test. Yeah, I know you did. Anyway, hope you did well. I'm sure you did well on it. Anyway, so how are blood cells made? With the bone marrow. And what kind of blood cells are made? White blood cells, red blood cells, and platelets. And remember, I talked pretty much yesterday about what a CBC with differential means and what it includes. And it's basically a breakdown of all the white blood cells. So you need to know that neutrophils are associated with acute bacterial infection, and lymphocytes are associated with viral or chronic bacterial infection. I'm sorry, I'm being distracted by Renee standing outside my door. I don't know what she's doing. She's dressed in black today. I have no idea what's going on out there. It seems to be fun. Anyway, so what was I talking about? Oh yeah, lymphocytes. That is a viral or a chronic bacterial infection. Eosinophils are associated with allergic infections, and monocytes are usually associated with chronic inflammatory disorders. So what diagnostic lab will the physician order to determine whether a patient is anemic or not? Well, I hope you chose an H&H or hemoglobin and hematocrit. Then we also talked about the matrices of the red blood cells, the different labs that are ordered to determine the characteristics of the red blood cells, because if they are altered, if the size and the shape is altered at all, it can affect the disposition of not only oxygen throughout the body, but the other functions that the red blood cells perform. So if we're talking about macrocytic RBCs, we're talking about someone that has a B12 or folic acid deficiency. If we're talking about microcytic RBCs, then we're talking about iron deficiency or thalassemia. I didn't mention thalassemia yesterday because it is an inherited disorder. And basically what that does is that it causes abnormal form of hemoglobin or inadequate amount of hemoglobin that is part of the red blood cell. One of the things that you can do to remember or differentiate between macrocytic and microcytic is, and to determine what the deficiency is that caused that type of mutation in the formation of the red blood cell, being B12 and folic acid deficiency, is that microcytic is due to iron deficiency. Iron. Micro iron. Does that help? If it doesn't, I don't know. Make up your own little mnemonic there. I don't know. Okay. So we talked about anticoagulant lab values, your PPT, your PP, and your INR. Why is an INR ordered? That measures the anticoagulation effects of Coumadin and warfarin, make sure that it is in a range that is normal for somebody that is taking that medication. Remember, we don't want the blood to get so thin that it won't clot at all. So we have to, people that are on anticoagulants have lab values taken frequently to determine that they're in the therapeutic range necessary to accomplish what we want it to accomplish, but not too little or too much. Okay, so what are the three vitamins and minerals that we need to produce for the human body to produce red blood cells? Is going to be iron, folic acid, and vitamin B12. Okay, we need to take that stuff in. We need to eat it, lots of it. So what are the signs and symptoms of anemia? We talked about having too few red blood cells. The signs and symptoms are going to be weakness and listlessness, fatigue, dizziness, lightheadedness, syncope, orthostatic hypotension, and there will be evidence of bleeding with a lot of bruising that takes place. You know what? I think that's all. It seems to me that there might be a question or two on sickle cell. I can't really remember. Anyway, that's what I had just little reminders for. I hope this helps. You know, you can always text me. You can always, on Saturdays, I have clinicals, so that would be a good day to do a face-to-face if we want to get on a conference on Canvas and answer some questions that you have specifically. Just let me know. I'm here for you. I want you to succeed. That is my whole reason for living, is to have you guys be successful and go forth and save the world. It's true. All right. Have a great weekend. Let me know if you need anything. Thanks.